Welcome to this session. In this video, we'll talk about beta blockers. Now, as a way of classification, there are two main classes of beta blockers. We have the non-selective beta blockers and the selective beta blockers. The non-selective beta blockers block both beta 1 and beta 2, while the selective beta blockers they block only beta 1. Okay. Now, between the non-selective beta blockers and the selective beta blockers, which of them do you think is of more advantage? The one that is of more advantage to us is the selective beta blockers. And the reason for that is because the main use of beta blockers is to treat cardiac diseases or cardiac condition. The main use of beta blockers is to treat cardiac diseases. That's why we develop the selective beta blockers or the cardioselective. These ones are called cardioselective. Okay. Now, this one that is non-selective, it has certain side effects because it also acts on beta 2, and beta 2 is located in the lungs. When it acts on beta 2, it is going to cause bronchoconstriction, and this is going to worsen asthma. It will act on the blood vessel. It will cause peripheral arterial disease. This is going to worsen renal disease. Renal disease is an example of peripheral arterial disease. It will act on the liver, and this is going to block the recovery from hypoglycemia. Okay, so these are some of the limitations of the non-selective beta blocker. They act on the lung and they cause bronchoconstriction. They worsen asthma. They act on blood vessels, causes vasoconstriction. They worsen peripheral artery diseases. When they act on the blood vessel, the blood vessel contain both alpha 1 and beta 2. So if they block beta 2, there will be unopposed alpha 1 action. That is why vasoconstriction is going to predominate in the blood vessel. Then for the liver, they will block beta 2 receptor on the liver, and that receptor normally mediates the recovery from hypoglycemia, hence it is going to affect diabetic patient. Now, having seen the advantage of selective beta blocker over the non-selective ones, what then are the use of beta blocker? So like I said earlier, there are two main uses. We have cardiac use and extracardiac use. Now we'll start with the first one, the cardiac uses of beta blockers. Now for the cardiac use of beta blockers, we'll go through all the cardiac diseases. You will see that beta blockers has role in each of them. So the first one we will discuss is congestive heart failure. Now in congestive heart failure, beta blockers have been used. There are about 3 beta blockers that are being used. We are going to see their names shortly. But in congestive heart failure, the heart is not pumping very well, meaning cardiac output is low. So if you should give a beta blocker, following normal understanding, you will notice that it is going to cause a reduction in the cardiac output. That is a reduction in the cardiac output for the short-term basis. However, why then do we not give beta blockers in congestive heart failure? The reason why we give them is because if the heart is continuously stimulated by the norepinephrine that is being released as a compensatory mechanism in an attempt to increase the cardiac output, if we allow the heart to be continuously stimulated by that norepinephrine, on the long run, the heart will undergo apoptosis. So to prevent that apoptosis, we tend to give such patients beta blockers. However, for a very long time, beta blockers were contraindicated in congestive heart failure. Reason because it was thought that they reduce the cardiac output, which is true. However, on a chronic basis, in order to prevent the heart from undergoing apoptosis due to constant stimulation by norepinephrine and epinephrine that are released during this chronic heart failure condition, we need to give such patients beta blockers so that the heart will not be overstimulated by the norepinephrine and epinephrine. Then again, beta blocker also block the release of renin. And renin, if renin is released, it's going to cause it mediate remodeling of the heart. So if you can block the release of renin, you are going to decrease cardiac remodeling. Okay, but take note that beta blockers are not to be given in acute or severe CHF. If a patient is coming down with CHF in an acute basis, you don't give beta blockers to such patients. Rather, you want the heart to pump very well at that point in time. However, on a chronic basis, we tend to suppress the cardiac output in such patients. Like we give beta blockers to prevent apoptosis in such patients. Okay, in the heart of such patients. Now, what are the beta blockers that we give? There are three main ones. We have carvedilol, bisoprolol, and metoprolol. These are the three ones we do give. Among these three, carvedilol is most preferred. Carvedilol is most preferred, and you start at a low dose. Then over weeks, you now increase the dose. Okay, so carvedilol is most preferred. Another heart condition in which we use beta blocker is arrhythmia. Remember, I said the use of beta blockers could either be cardiac or extracardiac. Another cardiac condition we use beta blocker is in arrhythmia. Now, in arrhythmia, beta blockers are class 2 antiarrhythmic drug. They are class 2 antiarrhythmic drug. And how do they work? One is that they decrease impulse generation in the SA node. They decrease the impulse generation in the SA node, and also they block AV nodal conduction. Okay, by so doing, they are useful in treatment of supraventricular tachycardia. They are drug of choice for this, for supraventricular tachycardia. Also, they are used in treatment of ventricular tachycardia, but majorly supraventricular tachycardia. You know, the SA node contains beta 1 receptor. Okay, even the AV node also contains beta 1 receptor. So when you give beta blocker, they are going to block the generation of impulses and also block the propagation of such impulses. Okay, they're going to cause AV block. So that is why we don't give beta blocker in a patient that is having Brady arrhythmia. You know, arrhythmia could either be tachy or Brady. So if a patient is having Brady arrhythmia, you don't give beta blocker because they will worsen it and it's going to cause heart block. Okay, so take note of that. Beta blockers are drug of choice for supraventricular tachycardia, and they are also used in ventricular tachycardia also, but they are contraindicated in Brady arrhythmia. Now, the third heart condition we give beta blocker is in angina or ischemic heart diseases. How do beta blockers work in angina? There are two major ways. One, they decrease the cardiac work. And they also decrease the heart rate. Now, if they decrease the cardiac work, it means that they are going to decrease the oxygen demand. And you know, in angina, there is the imbalance between the oxygen demand and the oxygen supply. So if you can decrease the oxygen demand, you are going to help that heart. Okay. Now, also, if you decrease the heart rate, it is going to increase the diastolic time. And you know, the heart normally feeds during diastole, so enough blood supply will be reaching the heart. Okay, based on you decrease the heart rate, and then you have more diastolic filling time, so more blood supply will reach the heart. So these are the two ways in which beta blockers work in angina: decrease cardiac work and decrease heart rate. Decreasing cardiac work will decrease the oxygen demand, so the heart can perform very well. Then decreasing the heart rate will increase the filling time, the diastolic filling time, and the heart normally feeds blood supply to the heart usually occurs during diastole, so more blood will be reaching the heart during by so doing. Take note that beta blockers are contraindicated in variant angina. Variant angina is a form of angina that is characterized by vasospastic nature of the blood vessel. The blood vessels are undergoing vasospasms. Okay, it is also called Prinzmetal angina. So they are contraindicated in this kind of angina. Okay, now the fourth heart condition is hypertension, or the fourth cardiovascular condition is hypertension. Take note that beta blockers are not the first line of drug in hypertension. They are rather what second line drug, and are most likely used in comorbid condition or to prevent the compensatory effect of other antihypertensive agents. Okay, for example, now other antihypertensive agents might be causing a reflex tachycardia. We can give beta blockers to such patients to prevent those reflex tachycardia. How will beta blocker work? They tend to decrease the cardiac output, and at the same time they block the RAS pathway, because in the heart we have beta 1. Also in this renin just like the glomerular apparatus, we also have beta 1, not beta 2, beta 1. Okay, so they can block this beta receptor. Take note that their antihypertensive agent is not vasodilatory. They are non-vasodilators. They primarily work on the myocardium to decrease cardiac output. and also block the RAS pathway by blocking the beta 1 receptor in the juxtaglomerular apparatus also. Then on a normal day, if you look at the blood vessel, you will notice that the blood vessel again has what? Alpha 1 and beta 2. So if you block beta 2, it means that, and you know beta 2 normally causes vasodilation. So if you block beta 2, you will expect a unopposed what? Alpha 1 activity, meaning it ought to cause what? Vasoconstriction, which is ironically you get. But on the long run, this based on the cardiac output being reduced, the blood vessel is going to what? Is going to adjust to the new cardiac output. That's why you will not notice any significant vasoconstriction when you are giving the patient beta blockers, okay, for hypertension. The main role of beta blockers in hypertension is to decrease the cardiac output, not necessarily the vessels. Okay, that's why they are not first line. They are rather what? Second line drug for hypertension. Then other miscellaneous condition we give beta blockers is in HOCM, hypertrophic cardiomyopathy. So we also give them for mitral valve prolapse. In mitral valve prolapse, there is a symptom, tachycardia symptom. So we give beta blockers to reduce the tachycardia symptom in mitral valve prolapse patients. Then also in aortic dissection patient, we also give beta blockers. In aortic dissection, there are two ways to treat it. You rapidly decrease the pressure because the enough blood is gushing out from that vessel. So you try to dilate the vessel so that the pressure will be reduced. So for that you give IV nitroprusside. Then also you want to also decrease the heart pumping activity, because the more the heart pump, the more blood will go into that ruptured vessel. Okay, so we're trying to give what? A cardiodepressant agent, which is the beta blocker in this case now. Okay, so that is for that. Then what then are the extracardiac uses of beta blockers? For the extracardiac uses of beta blockers, remember that the cardiac uses are majorly the beta 1 receptor, while the extracardiac uses are the beta 2 receptor. Okay, so first extracardiac use is in tremor, so anxiety induced tremors. We can give beta blocker to block beta 2 receptor. Remember that beta 2 receptor is present on skeletal muscle spindles. Okay, so we can give beta blockers to block beta 2 receptor on skeletal muscle spindle. For this, we can give propranolol. And give propranolol. Then also in hyperthyroidism, we can also give beta blockers. Okay, so to control the symptoms of hyperthyroidism like tremors and palpitations, we give beta blockers. Each one is going to block beta 2 receptor. The palpitation will block beta 1. Okay, then also the beta blocker also prevents the peripheral conversion of T4 to T3. T3 is the active form of the hormone, of the thyroid hormone. So if you give propranolol can block the peripheral conversion of T4 to T3. So this is very, very important. Okay, so that's another way in which it acts as an anti-thyroidism medication. Then in bleeding esophageal varices, we can give beta blockers for prophylaxis to prevent such bleeding in the nearest time. Okay, then also they are also given in migraine for prophylaxis also. For prophylaxis, migraine is a vasodilatory headache that comes due to the vasodilation of the blood vessels in the cranium or in the head. Okay, so we give beta blockers, propranolol for that. Then lastly, for glaucoma, we also give beta blocker as extracardiac use, so to reduce the intraocular pressure in glaucoma. For this specifically, timolol is used. Note, we don't use propranolol for this. All the other extracardiac effects so far, we've seen that propranolol is used, but in this particular glaucoma, we don't give propranolol because propranolol is a membrane stabilizing agent. It has the ability to block sodium channel, and if you block sodium channel, you'll be acting as a local anesthetic. Imagine you are giving a drug that acts as a local anesthetic as an eye drop to the eye. When there's an injury or insult or a foreign particle in the cornea, that blink reflex will not be activated, so the cornea will experience continuous irritation and continuous injury without the knowledge of the patient. Okay, that's why we don't give propranolol, rather we give timolol. timolol does not have this MSA activity. Then lastly, we will end with some of the properties of beta blockers. So the first property here is cardioselectivity. For this, we have the mnemonic is A, B, C, E, M, N. So for A, we have atenolol, acebutolol. For B, we have bisoprolol, betazolol. For C, we have celiprolol. E, we have esmolol. Esmolol is the shortest acting beta blocker. Then M, we have metoprolol. And N, we have nebivolol. So take note of this. Nebivolol is the most selective beta blocker, the most cardioselective beta blocker. Okay, so take note of that. Again, the mnemonic is ABCEMN. So atenolol and acebutolol. B is bisoprolol and betazolol. C is celiprolol. Take note of this one. Celiprolol, not carvedolol. Celiprolol. E esmolol, M metoprolol, N nebivolol, which is the most cardioselective. So all these ones, they are all safe in asthma patient, peripheral artery disease patient, and diabetic patient. They are all safe in there. Then beta blockers with intrinsic sympathomimetic activity. Here, take note, the major one here is pindolol. These beta blockers with intrinsic sympathomimetic activity, they are majorly partial agonists. Imagine you are a beta blocker, but you're also stimulating the same receptor you are blocking. That's what it means. So they block and they also act as partial agonists. So they are majorly used in old people to prevent severe bradycardia. You know, beta blocker normally cause bradycardia, but this kind of beta blocker that have ISA, intrinsic sympathomimetic activity, will cause less bradycardia. Example include what? Pindolol. So you can remember PAP. Okay, pindolol, acebutolol, and penbutalol. Then also you can still remember celiprolol, labetalol, and cartiolol. So remember CAR. Pindolol carries partial agonist-like activity. Pindolol, celiprolol, penbutalol, acebutolol, labetalol, and cartiolol. So remember cartiolol, remember PAP. Then PAP stands for pindolol, acebutolol, and penbutalol. Any of the mnemonic you want to use is fine. So the advantage of these ones is that they prevent severe bradycardia, useful in elderly patients that are susceptible to this condition, to this bradycardia. Then third, we have beta blockers with membrane stabilizing activity. These ones, they block sodium channel, like I've explained, and they have local anesthetic action also. Example is carvedolol, labetalol, acebutolol, metoprolol, propranolol, and pindolol. So you can see that pindolol is seen in both. So pindolol was also seen here also. Pindolol has ISA and also have MSA. So it has both, but propranolol only have MSA, not what? ISA. Then other ones you want to remember: acebutolol, metoprolol, labetalol, carvedolol. The mnemonic is C-LAMP, C-LAMP, C-LAMP. Carvedolol, labetalol, acebutolol, metoprolol, propranolol, and pindolol. These two P are what? Propranolol and pindolol. You might want to remember that also. So all of them are contraindicated in glaucoma. You don't give them to glaucoma because of corneal injury. The only one we give is timolol, and timolol is not part of them. Timolol is more like propranolol, but it has lost the MSA activity. Okay, so timolol is the only one used in glaucoma. Now we also have the water-soluble beta blocker. We have atenolol, nadolol, and sotalol. Take note of sotalol. Sotalol is water-soluble, so it is contraindicated in renal failure. It's contraindicated in renal failure because water-soluble drugs are excreted through the kidney. Then lipid-soluble ones that are highly lipid-soluble: propranolol, metoprolol, and timolol. The mnemonic is PMT. PMT. So you can see propranolol is highly lipid-soluble. So these ones, they can cross the BBB. They can cross the blood-brain barrier and cause insomnia and depression. Sorry, so you should avoid them in depressed patients. Then there's a last, as to conclude, there's what we call the third generation beta blocker. Remember that the first generation beta blocker are your non-selective beta blocker, while your second generation beta blocker are the cardioselective beta blocker. Now we're talking about the third generation beta blockers. These third generation beta blockers, they, in addition to blocking the beta receptor, they also produce vasodilation. Okay, now how would they produce that vasodilation? In various ways. One, they could block beta receptor and at the same time block alpha 1 receptor. Example is labetalol and carbidelol. Labetalol and carbidelol. That's why labetalol is very important or useful in a hypertensive emergency. Labetalol is also used in hypertension in pregnancy. Okay, so labetalol, take note of this. It is also alpha 1 blocker and at the same time a beta blocker. That's why it's a third generation beta blocker. Then we'll have carbidelol also. Then another mechanism that can act as a vasodilatory agent while still acting as a beta blocker is that they can have partial agonist activity in beta 2 receptor. Remember that the blood vessel has alpha 1 and beta 2. So if I'm acting as a partial agonist here, I'm going to cause what? Vasodilation. You know the function of beta 2 is to cause vasodilation. So if I act as a partial agonist here, I'm going to cause what? Vasodilation. That is the role of what? Celiprolol. Celiprolol. So take note of that. Celiprolol. Then some also act as calcium channel blockers also. Here we have carbidelol. This same carbidelol can act as an antioxidant again. So it's also part of the reason why it's also a vasodilatory agent. Then we also have the one that will open potassium channel. Here we have tilosolol. This is the only one here, tilosolol. With open potassium channel. Then lastly we have nitric oxide donor, that is nebivolol. Nebivolol. So take note of that. Now as a side note, note that esmolol is the shortest acting beta blocker, while nadolol is the longest acting beta blocker. Esmolol is very short because it is broken down by plasma esterases. Okay, it's broken down by plasma esterases. That's a short life of about 10 minutes. So that is all, just as a way of recapping before we end this video. I will just recap this last part of the lecture where I classify beta blockers. So we classify beta blockers under the cardioselectivity. We say A, B, C, E, M, N. A, atenolol, acebutolol, bisoprolol, betazolol, celiprolol. Okay, hope you know we saw celiprolol towards the end just now. We saw celiprolol towards the end. I believe we will also see it again. So esmolol also. Esmolol was the shortest acting beta blocker that is being broken down by plasma esterases. Okay, so take note of that. Then metoprolol, nebivolol is the most cardioselective. Then we also have beta blocker that are ISA, intrinsic sympathomimetic activity. Here the mnemonic was PAP. Here we have pindolol, acebutolol, pembutalol, we have cartiolol, labetalol, and celiprolol. Okay, again we are seeing celiprolol. So celiprolol is in the first and the second also. Then beta blockers with membrane stabilizing activity. Here we now have carbidelol, labetalol, acebutolol, metoprolol, propranolol, and pindolol. Then we now have the water soluble ones, ANS, atenolol, nadolol, and sotalol, that are contraindicated in renal failure. Lipid soluble ones, PMT, propranolol, metoprolol, timolol. Okay, so they cause insomnia and depression. Then the third generation ones, I've discussed all this one. So you can see celiprolol acts as a partial agonist on beta 2 receptor. Okay, so thank you very much. See you in the next one. Do well to subscribe and like this video.